minister was speaking about getting AI onto the ambulance and, having ambulance dispatch system that is AI driven in Africa. I mean, there's nothing wrong with it. I think it would be brilliant and it would be great. But how about we just meet the basic needs of the people? How about we just make sure that if you need an ambulance within the first hour, you can get it and you don't have to wait 3 hours to get it.
Across Africa, governments are exploring AI-powered ambulance dispatch systems. But what if the real challenge isn't artificial intelligence? What if the bigger picture is simply getting a trained clinician and an ambulance to a patient in time? In this episode, EMS paramedics from Africa discuss what really matters when building emergency medical services.
You just can't take the Bay of Plenty St John ambulance system and plonk it into a similar sized place in Africa and say, problem solved, this will work. It works in Bay of Plenty. Why wouldn't it work in Africa?
Yeah. Malusi, do you want to go first? Or?
I think it starts...
yeah, go for it.
Yeah. I want to say it starts with the Minister of Health realizing that they actually need an ambulance. And then they have a legislation that talks to the ambulance service. And then through the legislation, there is a university. Then the university will be created with a person that understands what paramedicine is, not a doctor, not a nurse, not a radiographer, a paramedic that understands what it is. And possibly someone that has good education, understands research, understands needs analysis and things like that. And then after that, the university will start designing courses that are going to train people within the community in how to become people that work in the ambulance service. I'm not sure. I don't want to say paramedics because that's now something else that is recognized by a specific council in the country. They must have regulatory councils and all that. And then after that, they will have an ambulance service. It starts with one ambulance and then it develops to what the needs analysis, as my brothers have said, that you need to understand what your community needs. I mean, if you have an aging population in the country, then you must have people, clinicians that understand how to check medication for high blood pressure, to assist patients that have fallen down in the midnight when they're going to the toilet, and then how to assess for neck or femur fractures, all those basic things, and have those tools. If you have an obese community or person that are and population that is large, you must have tools that are going to be used to elevate those people should they have falls. So basically, needs analysis and a structured approach from the legislation down to the person on the street.
Yeah, and I think while Malusi is saying that, I think there was a point where, and I think this is a conversation we had on the Para podcast as well, the minister was speaking about getting AI onto the ambulance and, having ambulance dispatch system that is AI driven in Africa. I mean, there's nothing wrong with it. I think it would be brilliant and it would be great. But how about we just meet the basic needs of the people? How about we just make sure that if you need an ambulance within the first hour, you can get it and you don't have to wait 3 hours to get it? Or perhaps, you only get a driver that comes out. You actually get a trained clinician that comes out to you to sort out your needs. So I think really sort of like meeting the basic needs first before we elevate to any other degree of trying to improvise our system. I think that's, and this is for Africa as a whole, really just making sure that if someone is in the rural areas, you don't have to wait for 4 hours. I think it should be the same for anyone else that's in the city, that should be getting an ambulance within 7 minutes. Obviously because of distance, we might not be able to get to you within 7 minutes, but you should be getting an ambulance, and the ambulance should be staffed with qualified individuals, and it must have all the equipment that you need, really. And I think that's basics. And I think until you meet that and you understand the needs of the people and you meet all those, I think then you run a quality and efficient service.
So is that where Africa is actually working towards, is providing a good basic coverage wherever you may live, with the best response times that are possible under the circumstances? Is that taking that very basic approach the way that Africa is that the way that the system there is developing?
I think just to start it off, let me start with Namibia, for instance, as an example. And as
Yep.
Malusi has highlighted, obviously you need a university that trains people. But now, once the university trains the people, there needs to be an ambulance service that absorbs these people. Because now, what's happening in Namibia at the moment is that you're having more clinicians being produced than the industry can actually take up. If you do have a need for ambulances, you do have trained clinicians, but then the Ministry of Health does not buy enough ambulances and does not have a structure in place to employ these people and make sure that it regulates the practice of the paramedics. There is a council, but then how do you make sure as Ministry of Health you just do not have drivers on the ambulances? You actually have trained clinicians. So I think that is the system that's currently lacking in Namibia, like a well-structured operational system that ensures that it's not only private run that runs the EMS, but also public, because public health is what reaches out to each and every individual, whether you have medical aid or do not have medical cover. So basically, that's where Namibia is sort of like lacking behind. And I'll allow Malusi and Tulani to sort of like share their experience from South Africa.
I was going to say that today I was
No, you
having a
can go
chat
ahead first.
with, yeah, I was having a chat with my mom, explaining to her the signs and symptoms of a stroke, and and then I told her that there are hours that we talk about. You don't need to waste time. If my mom were to call an ambulance where she is now, if she was having a stroke, it would take her possibly more than 3 hours, or let me say 2 hours, for her to be on the bed in
Wow.
ED. Yeah, it's far, and it's the and my mom has a private care, private health, so the nearest hospital is possibly 45 minutes away from here. Now that's a bit far too, but to get an ambulance might take a long time because of the distance. And I explained it to her, explaining it with another person that we know who called an ambulance. And I'm going to talk of a Gogo Dlamini, so it's a granny Dlamini that lives very far from the services. And whenever they call an ambulance, it takes a long time for her to get to. It will take 6 hours sometimes to call an ambulance. Or they say, nah, she's too old. We can't get there. So sometimes in the rural areas, it's hard. If you are in the deep rural areas, it's really hard. But if you live in the city, there will be competition to get there. There will be 4, 5, 6 ambulance services that can get to you if you call an ambulance. So it's really different from place to place, from country to country. Our main issue in South Africa was that the history of the service is that back in time, the ambulance services was found in the organized places close to the city because of the colonization system that was created. And then in the rural areas, no one cared for that area. Therefore, there are no ambulance services. But we can say that too, it's been 31 years post-democracy, yet the government hasn't built those services for the people that are living in the rural areas. So we have a lot of issues. I think in one of the podcasts, we talked to a guy from Nigeria. There was a boxer, a famous boxer, who was involved in a car accident. And the community had to actually extricate people from the ambulance because there was no extrication, not from the ambulance, sorry, from the car that he was involved in a car accident. So they had to extricate a person from the car and then organize for the people to go to hospital. The ambulance took a long time to get there. So it really varies from place to place. It's really hard to get things right in different areas.
I think from my side, just to add what Malusi and Adias has said, is that it's kind of like a seesaw, and I use that well aware of what I'm saying, is that there's certain things that have improved and there's other things that have not improved. Obviously, the EMS system in SA is quite unique to some of the EMS systems worldwide, is that we've got, the government ambulance service and also we've got the private ambulance services. Obviously, if you've got private healthcare insurance, I think this side we refer to as medical aid, but in the context of globally, people to understand is that we have to mention that it's private healthcare insurance. but also we've got your government ambulance services. Is that although people that can afford, they usually access private healthcare insurance, the government services are also trying to meet the demands. Although it might be a challenge, there's a lot of reasons why it doesn't happen. But I can say that from back when it was to what it is now, there's been some improvement in the EMS services, obviously more in the urban settings compared to the rural areas where there's still resource constraint. There's still also lack of EMS providers. There's lack of there's a limited use of vehicles and all sorts of things that we can talk. But if you look at the published papers, they do acknowledge the fact that the EMS is not perfect, but it is in some cases getting better, but it is in some certain circumstances not getting better. But in essence, those challenges, they're trying to address them.
Can I wrap up on a final question? And I don't know whether you can answer this or not, but let me try this question for each of you. From your services that you work in South Australia or London or New Zealand, take yourself to a on-scene road accident in those places. You're arriving on scene with your partner, paramedic, and you know you're very well resourced. Take yourself then to being a paramedic in South Africa or in an African country, but make it South Africa, arriving at the same scene. Where would you rather be? It's a difficult question, but I'd just really like to know, would you rather be in the ambulance in Tauranga in New Zealand or the ambulance in Cape Town as far as your resourcing, your training, your equipment is concerned? Because Cape Town is a sophisticated city, so it's as equivalent as I can get from Africa to those other countries.
Should I
I'll
start?
start with Malusi. We'll go around. Malusi will start with you, Elias, and then Kalani can wrap up his thoughts. So, Malusi, the tough question.
Okay, all right. I'd say from the bottom of my heart, I'd really love to be in South Africa. I'll tell you why. As long as I have my ICU ambulance bus there with me. I found a lot of fulfillment in treating people that are in serious needs. I really found fulfillment in that. I felt like I was making a difference. The accidents in South Africa were high impact accidents. You knew that you're gonna use the critical skills that we were trained to do. So in general, I'd say in South Africa, there is a high focus in emergency medical care. So therefore, the skills that you're trained for are really the high-end skills. In a car accident scene, an emergency care practitioner will arrive with a ventilator. They'll be able to RSI the patient on scene and then communicate directly with a hospital, tell them that they've got a patient that is RSI'd, they must get ready for with a ventilator, because you're going to hand over there. So I really felt that I'm really making a difference in the community, especially when I was working in the ICU ambulance. I really felt that because that's when I was working for the government. So I really appreciated doing that. Whereas in Australia, in general, accidents are not very common there. They do happen, but well, in South Australia where I live, there's a lower population, obviously. And sometimes once after 6 months, you'll see a really crazy car accident, but also there'll be one patient, but then the whole community will be affected because everyone will be sad because of that, Whereas in South Africa, I think the most I've been was 9 fatalities in one car accident, and I maybe had 3 patients that were critical there, and we had to transport them. So you do see the value of what you are bringing and what you are trying to do in the community. So for me, I'll say South Africa because of the value that I bring, and I do see that I'm making a difference in the community with the critical skills that I have.
Fantastic. Elias,
Yeah,
you've
I
got the
think
big
I was
question
sticking
now.
to the paycheck, but I don't think it was part of the elements that we're supposed to sort of like triage. But I think it will lean towards what Lucy was saying, and I think this is just how, and I think it's the value. How valuable do you think you are part of a community? And I'll give you an example. There are times where you have like a cardiac arrest in London, for instance. You get to a scene. You might be the first one to arrive on scene, and by the time that you turn around to grab your BVM, there's probably another crew arriving. And before you know it, there's probably like 4, 5, 6 crews that are on scene. And then you end up basically just, I don't know, collecting bags, trying to triage everything, trying to organize everything. You don't end up doing anything at all. And I think when you are in a resource limited setting, you are what they have. And the more you know, the better care that you can render. And I feel like there's just a lot of expectation that's on your shoulders. And you don't have a HEMS doctor that's coming to take over from you. You don't have a critical care paramedic that's coming to take over from you. So all that responsibility lays on your shoulders. I think it's a good and a bad thing. And I think it's good if you are well knowledgeable and you are well experienced. It's a good thing for the patient, because at the end of the day, it's not about you. It's about the patient. And I think in that aspect, it's good if you can give that quality care to that patient. But I think it's bad in the sense that I have been on scenes where it's just me, and I have like 3 patients or 4 patients, and I can't give everyone the quality of care that they deserve. I have to try and do with the resources that I have. So I think it will depend. But again, coming to what Malusi said, you do feel like you are making a difference. Some often, Namibia is not that highly populated. It's like a population of 3 million people. You might know someone that's related to this person that you're treating, and you're most likely to follow up and see how this person progresses through the chain of treatment. So I feel like there is that fulfillment that you get. And I think just overall, seeing that you are responding to your community and you are caring for them, I think that brings the fulfillment that you'll never get anywhere else.
Thank you. And Talani, your thoughts on the big question?
Now I was trying to run away from it. I thought you were going to change the question, but unfortunately, this is the last question.
Everybody has the same question to end our podcast.
So I think, Hamish, first of all, I need to tell you that this is an unfair question. However,
Chief.
however, is that coming from where I come from, is that when I look at what would I gain, is that there's high clinical autonomy and decision making in SA, exposure to diverse and high acuity pathology, ability to innovate and adapt in various settings in real time, but also to have an opportunity to shape the system's education and practice. Now, the systems in SA is that they would build me clinically, and also they'll help me to grow leadership and problem solving. But also there's something about South Africans is that we're resilient, and that contextual intelligence about the South Africans. Obviously, having to, if I would say I would choose South Africa, is that I need to think of what am I trading off. It would be the resource limitations, the system inconsistency, but also the financial constraints. Same sentiments as what Malusi has shared. And for me, I would rather be home to serve the community where I trained at, and also to contribute in a more positive impact to the community that I grew up in, that shaped me, that made me the person that I am, but because at the end of the day, it's the system that I trained in, something that I'm used to. We're used to making it work, although it's not the best medicine, but it's nice to serve the community that you come from. Whether I was working for a private ambulance service or I work for the government, it's nicer to serve the people that or the community that you come from. It's fulfillment. I mean, it's a sense of pride.
Sorry, Hamish. I was just gonna end off this, and it's just a joke there. And I said, hopefully we're not gonna lose our jobs after this, because then they're gonna think, we don't really want to be where we are. Just a disclaimer: we are happy. We are absolutely happy.
He's trying to get us fired.
But just to add to what Tulani was saying, and I think as much as we would enjoy working in South Africa there or Namibia or wherever in Africa. I think there are few aspects of it where the system just needs to take care of us as well. As much as we are dedicating to it, working 72 hours is not healthy. We doing like transfers that are 4 or 5 hours is just not fair on a clinician. And I think we earlier just today having a conversation with a few of the mates that have come to the United Arab Emirates, and they are like, I don't know how I made some of the jobs, the transfers, 5, 4 hours, and somehow you made it, and you just feel like there was a force carrying you. And I feel like those things are unfair. It's not healthy for the clinicians. So the system really needs to take care of the clinicians as well.
So the idea there is, you look after the service, but the service
Absolutely,
needs to look after
absolutely.
you.